Thank you very much, Tillman. Good morning, everyone. Thank you to the organizing committee for giving me the opportunity to present. So this is the outline I will be following. Why do we need non-invasive tests? What are the currently available non-invasive tests? Critical issue when using non-invasive tests, and what is the evidence in cirrhosis, and how can we use them in practice back to the clinic next Monday. So why do we need non-invasive tests? Because the liver biopsy is impractical. Look at the high number of patients with NAFLD in the population and the limited number of hepatologists and the even smaller number of pathologists. It also has limitation. It's invasive. It comes with morbidity and mortality, fortunately rare, prone to sampling variability, comes with a cost. But don't forget also, it's an imperfect gold standard. Let's say you have the whole liver, the unachievable gold standard. This is not Pierre Bedossa, of course. You all recognize this guy. If you have liver biopsy, it's still an estimation of a gold standard, the so-called best standard. Now, if you're doing non-invasive tests, it's an estimation of an estimation impacted by the limits of liver biopsy. So this has to be kept in mind when you're dealing with non-invasive tests. This is the usual slide, two different but complementary approach. The historical biological approach based on the dosing of serum biomarker, the physical approach based on the measurement of liver stiffness. We have indirect, simple, routinely available tests such as the LT ratio, APRI-FIB4, NAFLD fibrosis score, come for free, and the patented test for which the fibro test has been the pioneer, but you also have the ELF, the fibrometer, the EPA score. As for liver stiffness, the pioneer has been transient elastography, but we had new kids on the block, such as RFI, 2D shear wave elastography, and MR elastography. Now, there are critical issues when using non-invasive tests. Availability, cost, context of use, and applicability. And for instance, the non-patented biomarker, how widely available, whether MR elastography is not widely available. And they also come for free, which is not the case of MRE, for instance. And this influences, of course, the context of use. You're more prone to use in primary care biomarker than very sophisticated technology. This is common sense. Applicability also is very important and has to be taken into account. It's reliability and failure rate. And if you look at the two most validated tests, fibro tests, look, numbers are high. Fibro test has very high applicability, 99%, whereas we all know FibroScan has limited applicability, especially in obese patients and also in case of inflammation. So to summarize, the limitation of elastography technique, inflammation, obesity, is well demonstrated for transient elastography. We don't really know for the other technique. Steatosis is still a matter of debate, but we don't know about RFI, 2D shear wave, and iron for MR elastography. Quality criteria are very well defined for FibroScan, IQR on M, below 30% of the median value, not well defined for the other technique. Failure rate is high, but much lower if you're using the XO probe below 7%. I will get back on this later on. Units, kilopascal, meter per second, but for kilopascal you have different ranges. And this is important because according to the platform you're using, you cannot extrapolate because the scales are different. So quality criteria needs to be better defined for RFI and 2D shear wave elastography, and there's a need for standardization of units between the different platforms. Now, what is the evidence in cirrhosis? You can see we have several meta-analyses, large population, mainly of course in viral hepatitis, but now coming also in NAFLD. But what you can see, they are mainly for non-patented tests. Most of patented tests have not been externally validated independently from the developer apart from the fibro test. Now, if we going back to our case, NAFLD, this is meta-analysis on APRI-FIB4 and NAFLD fibrosis score, and the two latter are the most accurate and validated. Just would like to emphasize FIB4, for those who are not familiar, is age platelet count transaminase, widely available in the primary health care clinic. NAFLD fibrosis score is a bit more tricky. You need to know about diabetes or glycemia and albumin, which is not commonly performed in primary health care. So let's say we have a guy of 50 years old with normal platelet count and slightly elevated transaminase. The FIB4 is 1.01, and we know the negative predictive value is very high, 95% for excluding cirrhosis. So how are we going to use in our clinical practice next Monday when we are back to the clinic? So in patients with suspected NAFLD, this is what we should convey as a message to our colleagues as GP or diabetologists. Of course, you always must start ruling out alcohol and viral hepatitis. Then you want to rule out advanced fibrosis, and you start with serum biomarker. The FIB4, below 1.3, the risk is very low. You see the negative predictive value is close to 95%, and this is around 60% of the patients that you can rule out. And of course, you propose lifestyle modification, and you can discuss further reassessment. A lot of patients fall in the intermediate category, about 30%. This is, I think, the case that has been presented. And then you have the high-risk patients, about 15%. But if we want to convey to the other community a very simple message, it's a bit confusing. This is why I think you need to come with below 1.3. You do not refer your patient to an hepatologist, otherwise we will not be able to cope with it. You have to accept that some patients will be over-referred, and this we can discuss. So the hepatologists might use patented tests. One of the issues, this is one of the only study not independent from one of the developer, comparing non-patented and patented tests, and this is to the advantage of patented tests. But the issue is a slight improvement in accuracy is not balanced by the availability that is limited and the cost, and that limits the widespread availability of this test. And as I mentioned, no independent head-to-head comparison. Back to our algorithm, of course, you might come up with the elastography technique. And again, this is highly evidence-based, large meta-analysis, again, mainly in viral hepatitis. The most validating one, of course, no surprise, is transient elastography that has been around for a long time. Back to NAFLD and to our patient. To summarize, you can see the level of evidence in NAFLD is very high for transient elastography, not as high for the other technique. You can also quantify fat with CAP or MRI-PDFF. The failure rate, as I mentioned before, is between 3 and 7% if you're using the IXL probe, so close to the other technique. It's a point-of-care technique which makes a difference, of course, because you have immediate result in 5 minutes. Availability is wide, and the cost is acceptable as compared to the other technique. Thus, transient elastography appears as the tool of choice in this setting. How does it compare with serum biomarker? Again, we don't have many studies, but 2 independent studies from France and Italy, and the message is transient elastography outperforms serum biomarker for diagnosing cirrhosis. Now, the issue in your practice, which cutoffs are you going to use for cirrhosis? And if you look at the literature, there's been different cutoffs proposed according to different etiology. And the way the cutoffs are chosen is based on the OROX and the Uden index, maximizing sensitivity and specificity. But let me remind you that they are usually based on a single monocentric cohort and less than 200 patients in each cohort. I would like at this stage to introduce the spectrum bias. You see, this is an old paper from the New England Journal of Medicine at the end of 70s. And let's apply the spectrum bias using the so-called fiber test paradigm. I use the fiber test as an example. And let me introduce the DANA, the difference between advanced and non-advanced fibrosis. You should read actually significant fibrosis. This is F2, F3, F4. So you pool the difference between F2, F3, F4 and F0 and F1 in your population. So for instance, if you have an even distribution of fibrosis stage, 20% each, the DANA will be 2.5. If you have the worst scenario, only F1 and F2 patients, the DANA is low is 1. if you have the most optimistic scenario, only patients with cirrhosis and no liver disease, the DANA is 4. Now, back to our scheme. Let's see how it translates in terms of OROCs. If the DANA is 1, the OROC is very poor, is below 0.7. Bad test. If the DANA is 4, only cirrhotic and normal people, the OROC is close to 1. This is a bit suspect. I would not trust this test. So I'm still using the same tests in different populations, just to warn you that you always have to look at the spectrum bias, because there is a lot of noise in the literature on non-invasive tests, not taking into account the spectrum bias. Back to my scheme, you can see the prevalence of cirrhosis in these different populations go from 8 to 54%. So I'm not sure that the cutoff should be as high in alcoholic liver disease. It's just related to the fact that the prevalence of cirrhosis was very high. And actually, if you look on this table, sorry, it looks a little bit busy, but I'm trying to clarify. These are the different studies that have been performed in alcoholic liver disease over the last 10 years, and you can see the cutoff. Now, look at the prevalence of cirrhosis in these different cohorts. Now, let me reshuffle. And what is quite clear is a parallelism between the prevalence of cirrhosis and the cutoffs. The higher the prevalence, the higher the cutoff. Another issue is the influence of alcoholic hepatitis in alcoholic liver disease. And of course, I've taken alcoholic liver disease as a model for NAFLD. And look at the studies. Some don't even mention alcoholic hepatitis. And when it's mentioned, it goes from 10 to 60%, so highly variable. A recent meta-analysis from a French group established a cutoff, a median cutoff around 18.6 kilopascal. But look at the influence of transaminase and bilirubin, suggestive of alcoholic hepatitis. Then you jump to 26 kilopascal. If transaminase are normal and bilirubin total is normal, then you're back to what has been proposed in viral hepatitis, 12 kilopascal. So this is critical to take into account when you're deciding for cutoffs. So I think there's a need for a change in paradigm, because we started with elastography as a parallel, using Metavir scoring system and establishing cutoff. But liver stiffness is a continuum and should be used per se. And I would refer to what has been proposed by the Baveno group 4 years ago. The term is coined as compensated advanced chronic liver disease, or so-called CACLD. If you're below 10 kilopascal, the negative predictive value is high. So CACLD will be advanced fibrosis or F3, F4. Then cirrhosis would be more certain if you're above 50. But as I said, it's a continuum. So what you're measuring is a physical property, but also a probability of having advanced fibrosis or cirrhosis. And we know, for instance, if you reach 20, the positive predictive value will increase, but also the likelihood of having portal hypertension, and this will be dealt after in the next talk, also increases. Of course, if you decrease, then you increase the negative predictive value, and 8 kilopascal is close to 100% for ruling out cirrhosis. So now back to our practice. We are going to use the transient elastography, and I've shown you if you use the 8 kilopascal cutoff, the risk is very low for advanced fibrosis F3, F4, and of course for cirrhosis. And of course, you can follow your patient and attempt lifestyle modification and exercise. If you're above 8, you are intermediate to high risk, and then you need to decide whether you're going to take a liver biopsy or not, according to the cutoff, and screen for portal hypertension if you suspect cirrhosis. Then, of course, now we are performing a lot of liver biopsy because there are trials to propose to the patient, and that makes a difference. In case